So now I'd like to introduce our next speaker, who is Lana. There's been a couple of changes. Unfortunately, Valerie can't make it this morning, but Lana has fantastically said that she'll take the whole wrap and do it all. So Lana's worked in a broad range of community development, operational and management positions in not-for-profit sector, in the not-for-profit sector, as well as with state and federal government. 10 years ago, she established her own consulting business, honing her commercial skill and further developing her project management expertise. Introduced to the palliative care sector, Lana took up the CEO position, and while it was a steep learning curve, she has thrived on the opportunity to grow Palliative Care WA. Sorry, excuse me. Her leadership skills have been diversified into strategic priorities while maintaining its core business as the peak body within the palliative care sector within WA. Lana has revelled in the opportunity to lead the CEO roundtable on palliative care, delivered community-based workshops on advanced care planning, and engaged with traditional media to increase awareness and understanding of palliative care. I'd just like to say thanks, Lana.
Great, thank you. So my PAV man at the back, am I able to stand here? Beauty. So I'm not one for standing behind the lectern. So if it's okay with you, I'm just going to try and, present in front of you, and I will use the PowerPoint and yes, use this little who Jimmy What's It thing to move it along. So thank you so much for the opportunity to present to you this morning. I'd really like to make this session interactive. So I thrive off a conversation with you, questions from you. Your name tags aren't big enough. Oh, yes, they are. I could actually pick on you. I'm sure you don't want me to do that. But as I'm going through my presentation this morning, I'd really welcome you just to put your hand up and say, can you tell us a bit more, Lana? Or I'm not really clear about what you're saying. Because if you're like me, I think when I'm listening to someone, oh, I must ask them that. And 45 minutes later, it's gone. So much better to ask your question now rather than try and hang on to it. So is that okay? Are you happy with that? Beautiful. Okay, so thank you very much for the lovely introduction. So unfortunately, Val has a very unwell sister overseas, so she's not in a very good space this morning and felt like this presentation might be a bit difficult for her. So what we'd planned to do is I was going to talk about advanced care planning first, and then Val was going to talk about palliative care. So I'm sort of going to meld the two and we'll see how we go, if that's okay. That green one. Aha. Okay. So we're going to talk about advanced care planning first, so that I just get a little sense of where you're at in terms of advanced care planning. And I know that we have in this group some people who are unwell, as well as their family and supporters. But I'm actually going to ask this question of all of you, because our message is that advanced care planning is just not for people who are unwell. We all should be on the advanced care planning page. So those of you who felt like you were coming here just to be supporters, sorry. I'm going to be putting you on the spot as well and really encouraging you to start to think about this, because our message is that everybody over 18, so every adult, should start to think about, what would my priorities be if I became unwell? What would I like that journey to look like? And I'd really like to reinforce the previous presenter, I think it's gone now, about recognising that we are all individuals. No two of us are the same. So your clinical journey will be very different, as our previous speaker suggested, but so will your advanced care planning. So what works for Natalie, I can see yours, what works for Natalie might not work for Christine. We're very different. We've got different values. We perhaps have different cultural backgrounds. We have different life experiences, and all of those things contribute to a very different view of the world. So advanced care planning is for all of us, and I'd really encourage you to think about it now. So just a bit of humour to start with. So the brief version of advanced care planning, the woman says, we should talk about our final arrangements so the kids aren't burdened with it. So that's one of the key reasons why you engage in advanced care planning. So it's your voice, so that your children or your family members or your friends don't have to make these tricky decisions. And then Dad says, why should we care? That'll be their problem. You know, typical bloke, I've got to say. That's very sexist. Sorry to the blokes in the room, really sorry. And then she comes back and she says, right, well, at least we talked about it. Okay, so who is advanced care planning for? I'm reiterating my message. It's for everybody, young, small, elderly, parents. We all should be on this page. Okay, why is advanced care planning important? Oh, actually, before I start moving through this, can I have just a quick show of hands? Who has done any component of advanced care planning? So a conversation, a document, oh, a lot of you. Okay, oh, that's fantastic. Well done, you. So I'm sorry if some of this is repeating stuff that you already know, but not everybody put up their hands. So this will be useful for those of you who haven't put up your hands, but it also will be potentially a quick check for you. Have I done everything that I need to do? Because there are a few components to advanced care planning. So you might have done one bit of it, and there might be some other things that you might need to, or you might like to think about. Okay, so why is advanced care planning important? Because values and choices are named. They're not here, they're not at the back of your head, and you're not assuming that everybody in your network knows what you want. So that's something that we often hear in our community workshops is people who are unwell will say things like, well, my family knows what I want. That's a very common expression. But do you know what the reality of that is? They don't know. Exactly. They don't know. So that person becomes chronically unwell, perhaps has a hospitalisation. The emergency physician says to the family, okay, what's the plan from here? What do you think mostly emergency physicians and palliative care physicians hear? What's the response? I'm going to pick on someone. Sorry, I can't see your first name. Jill, would you mind just speculating what you think the response might be when someone's very unwell and the family are asked what the plan might be? Exactly. Exactly. Top of the class, gold star for Jill. Most people go, I don't have a clue. We've never talked about it. I just don't know. And then, of course, that causes huge stress because in a moment of crisis, people are having to make decisions for other people. So what do? We get on the advanced care planning page, we think, we reflect, we talk, we plan, we write. I'll get to that model in a minute. Okay, for those of you who are planners, it's about planning ahead, not leaving it to the last moment. It's also about determining who's going to make those decisions when I can't. So you may end up in a circumstance where you're not able to make decisions. What we encourage you to do in the advanced care planning process is to think, who do I trust in my network? Who do I trust that will make decisions in my best interests? That's a really it's a really profound, it's a really important consideration, and one that should not be taken lightly. It's a really significant responsibility that you're asking someone else to take up. Helps avoid unwanted treatments. So one of the implications of our increased medical knowledge and expertise is that there is, as the previous presenter talked about, there is lots and lots and lots of treatments. And for some people, they may get to a point where they say, look, actually, I don't want any more treatments. I've had enough. Or they might say, look, I'm interested in this treatment and that treatment, but no way am I interested in that treatment or that treatment. So it's about encouraging you to start to think about what's best for you. It's recognizing that the control is with you. The control is not with the health system. The health system presents you with options. You make the decisions. It's your body. Very important to recognize that. And the other important thing that's now happening in hospitals, you may have heard of the goals of care process. So if you are repeatedly being admitted to hospital and it looks like your health is deteriorating, it will prompt a process within the hospital where a clinician will have what they call a goals of care discussion with you. Okay, so we're recognizing that there's lots of hospitalizations happening here. Looks like you're starting to deteriorate. What are our shared goals moving forward? What would you like to happen next time that there's an admission? So what we're saying to you is if you're on the advanced care planning page, you will understand some of these concepts and terms. And so when you have a goals of care discussion, you'll be going, I know what he or she's talking about. I've already been on this page. I've made some decisions. I've written them down. I know what the clinician is talking about. Does that make sense? Yep. Okay. Any comments or questions on any of that? Yes. Really good question. So for our people online, we've just had a question from, Carolyn, who's saying, what if you change your mind? That's such a brilliant question. Advanced care planning is dynamic. It is dynamic, and we all change our minds about everything, don't we? So absolutely, you can write an enduring power of attorney, you can write or you can nominate an enduring power of guardianship, you can write an advanced health directive, and you can change them tomorrow. So don't be frightened about putting pen to paper. You can change them at any stage during your journey. And in fact, what our message to people is, if you do get on the advanced care planning page and start to write some documents, put them in your file with your insurances, you know, those dastardly amounts that you have to pay annually. Put your advanced care planning stuff with them so that you look at them every year. Just have a quick look and say, do they still, is this still relevant? Is this still what I want? Have circumstances changed? Do I need to change my ACP documentation? Yeah. So I'm going to, you're fabulous. You're well on the page. In fact, what I might do now, seeing as you've flagged some resources. So we've got this information on our Palliative Care WA website, but I've just, look, Natalie, would you mind? Yes, please. Could you just put a pile on each table? So look, there is a lot of information out there about advanced care planning. Can I suggest to you some of it is really confusing? So what Palliative Care WA is trying to make it simple. So the sheet that's being handed out is internally we're calling it ACP for Dummies. So it's trying to make it as simple as possible for people. And I'll get to it in my PowerPoint, but really good question. I would encourage you, and I'm a bit biased, go to the Palliative Care WA website. We run workshops on advanced care planning. We've got resources on advanced care planning. And interestingly, we're about to start a service to help people complete their documentation. All right, moving on. Okay, so this is where we're up to. So in fact, could I just grab one of those sheets, please? Sorry. Okay, what I've handed out to you is our advanced care planning for dummies. All right, you're not dumb, but it's a play on that concept about trying to make it simple as. So could I encourage you to look at the diagram which I've got up on the PowerPoint. So basically we say advanced care planning is 4 stages, 4 simple stages. First stage is think. This is about you. It's not about your husband or your wife or your children or your grandchildren or your lawyer or your treating team. It's about you. So what we encourage you to do first is to think about what you want. What's important to you? So our previous speaker was talking about the fact that, you know, some people, when they develop chronic disease, you know, if they are 90, they've had a full life, they might go, actually, this is my time. I'm quite happy to go. So I want minimal treatment. I just want you to let me go. But equally, there might be a 90-year-old who's loving life, saying, oh, I'm not ready to go. I'm going to fight this every step of the way. And so that's their priority, that's their prerogative, that's their right as an individual. So what we want you to do first, and most importantly, is think. So some treating teams, and I'm not being critical, really want to focus on the forms. That's really difficult. To go to the forms first. What we encourage you to do is to do the thinking, the talking, and then you go to the forms. When you've formulated in your head what's important for you. So think first, then talk. Now, these conversations are difficult. When there's no way I'm saying these are easy, but you know, they're important. So try and make a time. Do it in little snippets, maybe. Trying to have a full-on conversation about these really important things, you know, for an hour at a time, that's really hard. So little snippets, just say, okay, can I just run some thinking past you? What do you think? And having those conversations with other people will help you clarify in your mind what's important for you. Obviously, you need to talk to your GP and your treating team. They've got the clinical knowledge. They've got the knowledge of your health background. You can go to them and say, look, this is what I'm thinking. What do you think? They will have an opinion. They will share their expertise. Again, it's up to you. What we then say is, you know, you might have spent a few weeks thinking and talking. And then there's a range of documents that you might consider completing. So on the back page of this little document is a summary, is a really high level summary of the documents. They're written in easy English. So we've tried to take out as much jargon as possible to make them as clear as possible. So, and the first document is actually being reworked with WA Health at the moment. So it might end up being called something else. But basically the first document, and you can get this from us or you can get it online, is a story. So you might say, and this is just right off the top of my head, you might say, look, I've got a chronic disease. I'm aware that my life expectation has reduced. I want to stay at home for as long as possible. I want my family to care for me for as long as possible. If I need to go into hospital, I want those hospital stays as short as possible. When I require palliative care, I want Silver Chain to come in. I want palliative care at home. I want you to allow my cat and dog in the room at all times. They are really important to me. They help me mentally. My mental health is significantly improved when I can cuddle my cat and dog. Please remember that I'm a vegetarian, and even when I'm really unwell, please don't give me meat. I love my feet rubbed. So when I'm going through a tricky time, please, if someone's available with some massage, or can you please give my feet a rub? That'll really, really help. So you get what I'm saying. It's a story. It's a high level story about what you want. And that's your first step in advanced care planning. Just getting down a story. You can write it however you like. Dot points, paragraph, pictures, whatever works well for you. The next one is making a will. Of course, that's really important. You've worked really hard to gather your wealth, your house, your property, your yacht, whatever you've got. Important so that you're making the decision about where that stuff goes. What happens if you don't make a will? Who else can I pick on? What's your name? What happens if you don't make a will? Who decides what happens to your goods and chattels? That's right. Yeah, legislation. So do you want legislation to determine what happens to your goods and chattels? No, you do not. I really encourage you to have a will. Who's got a will in place? Okay, that's fantastic. Who's looked at their will in the last 12 months? Yes, okay. You need that in your advanced care planning folder. Make sure, so going back to your question, make sure your will still reflects your current circumstances. So, you know, families have divorces, stepchildren, you know, you might have got an inheritance from Uncle Sam that you didn't think was coming, didn't even know about. Things change. So you need to make sure that your will reflects what you want. Next one is organ and tissue donation. So for many people contemplating the last stage of their life, they want to think about what they can give back and what they may be able to donate. Yes. That's probably true. What I say and what I know from the organ donation people is they say, let us make the decision. You know, so give them the option to retrieve whatever they might be able to retrieve. So, you know, that may be absolutely true. But, and of course, in some of the workshops that I do, you know, I've got 80-year-olds who say, oh, don't think my heart's going to be much good for anybody else. You'd be surprised. And what the donation people say is, let us make the decision. Whatever, that's right. But you know, your heart may be in great shape, even though you're older. So it's about, don't you cut yourself out, you let them make those decisions. And then we move on to the enduring power of attorney. So that's the really important document where you appoint a substitute decision maker. Does anybody know what the focus of an EPA is? Let me pick on somebody else. Anne, do you know what an EPA is about? Beautiful. So Anne, for the people who are online, Anne has just said, she used the word higher end choices rather than lifestyle and health. That's right. I probably wouldn't use that term, but you're absolutely right. Enduring power of attorney is goods and chattels, is finances, what's going to happen to your property, your house, etc., etc. So it goes with your will. Many people unfortunately think, oh, I've appointed my enduring power of attorney. They can make choices about everything. No, they cannot. Enduring power of attorney for money, enduring power of guardianship for health and lifestyle. You need both. You need both. One goes with the other. Yes.
Guardianship. Oh, sorry.
They can't hear the question.
Sorry, they can now.
Yeah, okay, beautiful.
Just the guardianship.
Yep.
Isn't your partner, husband, wife, children, your automatic guardians?
Yes.
So if you choose to have somebody different,
Yep.
you need one. Otherwise, that's okay. Is that my understanding?
So what we have in WA is a list that health professionals use to determine who can make particularly health decisions. So on that list, it's an AHD at the top, an enduring power of guardianship next, then your wife, then your children, then your siblings. So it goes down in descending order. So our recommendation to you is that if you don't have an advanced health directive, and we're getting to that in a minute, the next thing is an enduring power of guardianship. It just means that you are directing health professionals to the person that you want to make those decisions. So it may, you might say, look, I don't need one. I trust my husband. He can make those decisions for me. The problem is if they can't access your husband, he's over in, the Philippines doing business, they will go down that list until they find someone who can make that decision. The risk is, and it may not be a huge risk, they might get down to your sibling, your brother whom you haven't seen for 20 years and whom you are estranged. He could end up making a pretty significant decision about your treatments. And, respectfully, I suggest that's not what you want.
Making advanced health directive is that if there's conflict between family and you can't speak for yourself and you haven't set anything up, then that goes down a completely different track of possibly a state admin tribunal hearing to appoint a guardian who may not be who you choose.
Yep.
And it's very difficult then to try and do what's best for you. So there's that's a big value of actually trying to make your own voice
Sorry,
speak.
What's your first name?
Mary.
Mary. So Mary's raised a really good point about family conflict and about the fact that your partner, your children, your grandchildren's views might be quite different to yours. That's one of the intrinsic values of an advanced care planning process, is that you start to talk about this stuff. So just as a really simple example, the organ and tissue donation, if you haven't told your family that you're an organ and tissue donor and you unfortunately end up in a circumstance where you're on life support, if your family object, what happens? Who can I pick on? Yep, that's right. So if your family objects, it doesn't happen. Now, the organ and tissue donor people rightfully say, look, we don't want to further exacerbate family grief, so we won't go against their wishes. But the implication of that is that your wishes are not being adhered to. So the message is we need to talk about this stuff. And we recognise in families there is often conflict. There are often different values and different priorities. We need to talk this through so that if you appoint an enduring guardian, they then are very confident or comfortable in what your choices are and confident that they're not going to be obstructed by other family members. Does that make sense? It's all about having the and look, sometimes it won't get resolved. We're not saying that this is a panacea that's going to fix all family issues, but much better to talk about it way earlier than at the moment when someone's really unwell and facing significant healthcare decisions. Any reflections on that? Does that make sense to you? Yep, beautiful. All right, and then the last one on our list is the Advanced Health Directive. Now, that's the most powerful document in WA. So this is a treatment document. So it's not a lifestyle document. It's about your treatments. So you'll be possibly aware that we're significantly reworking our existing document, which is pretty shocking, pretty poor. but the new document will really help you to make significant decisions about what treatments you want and what treatments you don't want. The AHD is enshrined in legislation, so medical practitioners must follow it. The only way the only rationale that they can use to not follow it is if it doesn't make sense to them. And unfortunately, we've seen some pretty poor examples of advanced health directives. So my really, really, really clear message here is that you must consult with your treating team, your GP, your treating team, your hospital team, whomever it is, you must consult with them to make sure that you get your AHD as clear as it possibly can be in language that your clinicians will understand. Does that make sense? Any questions on that? Ah, beautiful, beautiful. So if you're going to your GP, for example, recognising GPs have very tight timelines, please make a double appointment if you're going to discuss your advanced health directive. And exactly as Angela said, you know, do your thinking and your talking way before you get to your GP. Have some really clear ideas about what you want to say, and then make your double appointment and go to your GP and say, look, here's my thinking. What do you think? And even have it drafted out. And we can give you some help with that. But absolutely, yeah, you need to go there really empowered. Yes.
Can you change? Can you change the advanced health directive easily?
Exactly as I said previously, you can write an advanced health directive 1 week and then have a complete change of mind, and the next week write a new one and say the previous one is rescinded. This is my new AHD, and this is the one that I want to be followed. So dynamic, responsive, you can change them whenever. Microphone. Yeah.
Oh, sorry.
That's all right.
So what happens if you're at a critical point and you've got some well-meaning doctor trying to persuade you that, you know, this is going to be fantastic, but you didn't kind of realize that was where things could go, and you're like, now what do I do? Oh, do I change my mind?
Okay, in that circumstance, and that's a really tricky circumstance, I recognise that, I would be encouraging you to obviously hear the advice of your clinicians, but if you've got an enduring guardian, I would be encouraging you to use that person to advocate for you. So, you know, you'll have had discussions with them. They will know what your wishes are. Hopefully they're in hospital with you. You could have a conversation with them about, okay, you know, look, this is really tricky. I'm not sure which way forward. Can you help me? Can you support me? Can you advocate for me?
So you can still change right at that.
You can. If you've got cognitive capacity, you can make those decisions right until the end.
And who gets to decide that?
Basically, you have cognitive capacity unless someone deems that you don't. And then if someone deems that you don't have capacity, then an assessment needs to be made.
I think what you've written in an advanced care plan never substitutes what you're thinking in real time or deciding, as long as you have capacity to decide.
Yep.
So you in the room with the doctor, if there's a change of treatment plan path, you say, well, I want to go this way. So the medical staff are going to be listening to you, not reading your advanced health directive. The advanced health directive is valuable when you can no longer make those decisions. Yep. So you in real time trumps the advanced health directive.
Absolutely. Yep. Yeah. So important to recognise the EPA, the EPG and the AHD, exactly as you've said, are there when you don't have capacity. But, you know, that's an important part of advanced care planning. But What's led up to that is a lot of talking and thinking and talking. And from our perspective, that's as equally important as the forms. How are we going for time?
Not too bad. We just have a question.
Right.
The Advanced Health Directive, does that get lodged somewhere at a hospital or
really
hidden
good
away
question.
somewhere that can be accessed?
Yep, really good question. Thank you for asking you that. So we're in the middle of hard copy world and electronic world. So what we recommend is that you make hard copies of your EPA, so your story, your wishes document, your EPA, your EPG and your AHD. Make hard copies of them, give them to your partner, your children, your grandchildren, spread them about. Make sure that people have copies and they know what you want. You can also upload all your advanced care planning documentation to My Health Record. So who's connected to My Health Record? Quite a few of you. Yep. So you can upload those documents to My Health Record. Also, our hospitals in WA have a system whereby, particularly for the AHD, if you have an AHD, we encourage you to lodge it with your hospital, and then an electronic alert will come up. So if you get admitted to emergency, there'll be an electronic alert that says there's an AHD in place. Their challenge then is to find the AHD, which is why you need your partner and your children and your grandchildren to have a copy, because they can go, here's the AHD. Flagging with you that WA Health is looking at setting up a register for your AHD so that they will be able to be accessed easily. Sorry, I'll come to you. Yep.
Hi, just a question about what's the difference with treatment decisions under the EPG as opposed to the AHD?
Right, so as I was talking about earlier, there's the hierarchy of decision makers. The AHD is at the top. So the AHD trumps everything else. If you don't have an AHD, the next under that is the enduring power of guardianship. And then underneath that is your spouse, and underneath that is your children, underneath that's your siblings. It goes in a descending order. Yeah. And there was, yes.
I've often wondered about My Health Record and who actually reads it. You know, we can upload these documents to it, but what happens next? Do clinicians, as part of their standard operating procedure, ever look at it? No, it's your record for you to control, and you determine who has access to it. So, but it's an electronic platform where that documentation is there. If you want your hospital to be able to access, you can give them permission to do so. So it's controlled by you. Okay. I'm just aware that, how's my time?
About 10 minutes.
10 minutes, okay.
Was there a question we missed? No?
Okay, so we've been through that. Okay, so what I want to reinforce with you, and this is for all of you, whether you're unwell or not, is Palliative Care WA is funded by WA Health to run workshops on advanced care planning. So a couple of hours, we have good fun. It's not sad and I can't think of another word. It's engaging. Thank you. It's not morose. It's because advanced care planning is about being empowered. It's about being in control of the last stage of your life. So it's positive. It is really positive. So we run 2-hour workshops. We can do that with your network, your group, your social group, your recreational group. We'll come to you. We'll run the workshop. We present you with a folder that's got all the hard copy information in it. So that's a critical first step. So I've given you an overview, but the workshops, really drill down into much more detail. The other thing that you can do, so I've handed out the little postcards on our new service, which is our Palliative Care Helpline. That line is not a clinical service. It's a service staffed by palliative care nurses and pastoral care staff. So for anybody in the community who wants to have a conversation about advanced care planning, about palliative care, about grief and loss, you can ring this phone service. So it's 7 days a week, 9 till 5. You can talk for as long as you like. The aim of this service is to provide support. It's not clinical support, because we've got these people doing that job fantastically well. This is about supporting you emotionally, psychologically. We don't provide counselling as such, but we listen, we support, we provide information, we help you to navigate, we support. So I really encourage all of you to consider that. So people who are unwell, their family, their friends, you know, if you're in a space where you just want to talk, and perhaps you want to talk to somebody who's not part of the network, you want to talk to somebody who's a bit independent or a bit removed, please ring us. We've got staff ready to talk for as long as you would like to. So they are the two resources we've got. As you can see, I've got the website up there as well. All of this information is on the website as well. So how much time have I got left? 7. It's 8 minutes. Beautiful. All right. So if that's okay, can we just move on from advanced care planning? I just want to talk very quickly about palliative care. Val's going to be really disappointed that I took up all the time talking about advanced care planning. So my quite simple message about palliative care is to encourage you not to be fearful of the concept of palliative care. So when we talk in community, many people say to me, as soon as I hear the word palliative, I get really anxious because I think it means I'm going to die tomorrow. That is the commonly held view of what palliative care is. Can I suggest to you that palliative care is far from that? So ideally what happens is that you get linked into palliative care at point of diagnosis. So when you know that your life expectancy is reduced, and look, you know, you may have 2, 3, some people have been in palliative care for 5 years. So it's not about managing that last stage of life or the end of life, it's the last stage of life. So palliative care, as our previous speaker said, is a holistic service. It's a multidisciplinary service. So we have clinicians who help to manage pain and symptoms, but we also have social workers who work with people and their families. We have spiritual support people who can help you manage your response to the last stage of life. But most importantly, we support the family. So we don't just see the unwell person, we see the unwell person in their family or their community or their network, whatever that might look like. So many people say to us, it's not until I got to palliative care that I felt like I was a part of my loved one's care. So look, I'm not saying that we're as well resourced as we could be, because we're not. We're far from that. We're having ongoing conversations with Minister Cook how to better resource palliative care in WA. But I would really encourage you sooner rather than later to start to think about, okay, if I have a chronic disease, if I have a life-limiting diagnosis, let me just find a little bit about what palliative care can offer me. Because interestingly, and this is not a reason to access it, but the research is very clear that people who access palliative care actually live longer than those people who don't. And that's for a whole raft of reasons, you know, better clinical management, better mental health, all the sorts of things that our previous speaker was talking about. So I really encourage you to think more positively and less fearfully about the notion of engaging with palliative care. So this is a really important slide, I think. It's recognising that there are two experts in palliative care, your treating team and you. So again, it's that notion of empowerment. So palliative care is about you in control of what's happening and maximising the resources that are available to you in your world. So known benefits of palliative care, fewer hospitalisations because people are in control. They've made decisions about what they want treated, what they don't want treated, how they want that treatment to look. And the evidence is very clear that it results in fewer hospitalisations. As I said previously, and you know that little story, if I get admitted to hospital, I want to be there for as short a time as I possibly can, and I want to get out. And in fact, the evidence really supports that. Less visits to emergency departments. Again, that's probably because people have got a plan. They're clearer about what's happening. They're clearer about their choices, and it's most often managed better so that people have less need to have the emergency trips. Improve quality of life for the person and their family. And that's what palliative care is about. It's about maximising the quality of life for the last stage of life. As I've already talked about, it's a holistic in its approach. You get care throughout the treatment journey. And of course, from our perspective, the critical beginning of your journey with palliative care is to engage in advanced care planning. So again, it's about you making decisions, you being in control, you being empowered moving forward. The other important thing here to recognise, I'm not even sure if it's on this slide. No, maybe it's on the next slide. Can't find it. Important to recognise that palliative care can be delivered in a variety of settings. So you can receive palliative care at home with a skilled GP. So generalist palliative care. So, you know, if you have really complex symptoms or clinical presentations, you might need to access specialist palliative care. So that's palliative care services that are based in hospitals. But most people don't actually require access to specialist palliative care. You can access what we call it generalist palliative care. You can receive that at home, managed by your GP. You could receive that at your home with support from Silver Chain, who are set up to do that. In regional and rural WA, the McGowan government has invested significantly in palliative care teams throughout regional and rural WA. So our people online who are from regional and rural WA, you can access specialist palliative care teams in your regions. You can obviously receive palliative care in hospice, and we have a few hospices in WA. Important again, though, to recognise that when you get admitted to hospice, it doesn't mean that you're going to stay there until you die. The hospice model is about delivering quality palliative care. So if you are stable and well, relatively well, then you can be discharged and sent home and then readmitted to hospice if things deteriorate. Obviously, you can receive palliative care in hospitals, but also increasingly people can access palliative care in aged care. So we have some aged care providers who are becoming increasingly skilled with on-site GP and nurse support to be able to provide good quality palliative care and aged care. There are some aged care providers who've got a way to go, in terms of doing that. But that's going to be the way of the future. Increasingly, people will spend the last stage of their lives in aged care, and they will be able to access quality palliative care as part of doing that. Okay, and end up with a cartoon. Someday we will all die Snoopy, true, but on all the other days we will not. So I think I'm done in terms of time, unless there's any other questions or reflections that anybody would like to share with me. Right.
So Lana, I was just wondering how many people have had access to palliative care or do see palliative care in the rooms.
Can we have a quick show of hands? Who's linked into palliative care at this stage?
I just wanted to say we both work in palliative care, and I can say every single patient on admission is fearful. The families are fearful. We're a short stay unit, and pretty much every single patient never wants to leave us. So
or never wants to leave you once they've connected with you.
Yeah,
it's getting over that fear thing, isn't it? Yeah.
And the best experiences are when they come back, maybe they have a pain crisis or something, they're really pleased to see us. And so it's just going over that hurdle of the fear, and it doesn't mean end of life. And like you say, I mean, it can go on for many years.
Yeah, exactly. So unfortunately, thank you for reinforcing that. And if I'd known you both were palliative care experts, I would have been a bit more reflective about what I said. But sorry, what was your name? Debbie. What Debbie said is absolutely true. We actually do have an image problem. Unfortunately, look, and I think it's reinforced by the fact that because as a sector we're not resourced as well as we should be, it often does mean people only are treated right at the end of life, and that reinforces the notion that that's what it's there for. But what I encourage you, so this is people power, is to really say you want access to palliative care. If that fits for you, ask for it, pressure for it, and get your enduring power of guardianship to advocate for you. No, and it's different for different services. So look, what I'd be encouraging you to do, you and whomever is talk to your GP and say, look, I'm really wanting to develop that relationship. So I think it was really interesting that you focused on the fact that they're pleased to see you, because it's about getting to know your palliative care providers, trusting them, building that relationship so they understand you, they understand your needs, and so they can go on that journey with you. Very hard for these people to engage right at the end and be effective in the delivery of palliative care. Hang on, Mo, can we just get, I'm coming to you. Time. Okay, all right, I'll just ask. Yeah, okay.
Due to barriers, people being fearful, even medical staff not understanding palliation, we get lots of patients come to us almost already terminal.
Yeah.
They're sometimes with us for 24 hours. We don't get to know the patient.
No.
We don't get to know the family. That's not delivering good palliative care.
Certainly
That's
not.
more traumatic in a lot of cases, moving that patient at end of life.
Yep, absolutely. Yeah. So I've been told I'm out of time. Can we just ask this lady over here? Because she's had her hand up for a very long time.
Just how wonderful you guys are.
Oh,
absolutely incredible. I'm a teary person, but that's okay. But I'm not caring for my sister. But the interface that palliative care provides is just, it's so amazing. Like I can look after Claire, but medically I can't. And the anxiety around her pain, and because I can't do anything about that, but you guys can get it to a place where it's manageable. And the relationship we've built up with our Pally team out in Rockingham are incredible. They're just so they're a breath of fresh air. They come in, they're calm, they know what to do. It takes
Nicolotting.
all your anxiety away.
Yeah.
And they're just so clever, and they just manage it. And it's just, you ring them up in the middle of the night and you've got a problem, and they'll come out and sort it out and do whatever they got to do. And it's just like, oh, far out. We can stay home still. We can do our things. And as a carer, it's just like having a bucket, a mountain load of help and support that you can do what you need to do to provide care for someone who can stay at home and just live life and do what you want to do and continue that. But the relationship is incredible. It's just so beautiful and very precious. And that time that Claire's had a lot of, palliative care intervention and relationship for some time, because she's one of the long ones. It's amazing. But the team at the hospital, we know everybody. They're just, oh my God, I can't advocate more for the palliative people to get involved as soon as you can. And it's not about you're going to be going soon. It's about having that quality while you're going, along the way. They're just incredible. Please just touch base with your Pally teams. They're incredible.
You've done that way better than I could ever do that. Thank you so much. Okay, I can't say any more than that. That was just beautiful. Thank you so much for sharing. I'm going to hand over to you.
Same for morning tea, or have you got to go? All right, so I think that's a really nice place to stop. Everybody's crying. So just a couple of things I wanted to check with Lana that we were sort of talking about with the AHD. At the hospitals that we work at, if you do have a hard copy, it can be filed in the notes if it's a hospital that still uses a wad of notes. And equally with the electronic ones can be added to your electronic medical record as well. So that's one thing. And the other thing that patients are often told is to stick it on the fridge in case there's a 000 call, so that it's there, it's accessible. They've not got to wade through the filing cabinet and find it amongst all the other documents. Have a copy there too, but if there's one more easily accessible. So I just really like to thank Lana. That was fabulous. That was well done. Thank you. And I'm sure you'll get a lot of people getting in touch with you from now on.